All right, so welcome everyone to our most recent installment of the Mocs Move Forward Diversity Discussion Series. I'm Teresa Blackman, I'm the Pre-Health Professions Advisor, and today we are talking about diversity and inclusion and why it is super important in healthcare. And so we've got Dr. HB joining us.
Greetings.
So I didn't know if you wanted to give a brief introduction of our guest speakers.
Sure. Well, good evening, everyone. My name is Dr. Shwani Howard-Baptiste. I am the Interim Program Director for the Masters of Public Health here at UTC and also an Associate Professor in the Department of Health and Human Performance. So we are so excited, one, for me to see my students, my second year Masters in Public Health students on this call. So today, as we talk about Mocs moving forward, we want to talk about what does diversity in healthcare look like, specifically looking at African American, possibly the Latinx population in regards to health disparities when thinking about maternal and child health. I also have my co-conspirator in this whole MPH Live, Ms. Shannon Colvin, who's the Associate Director for the Masters in Public Health here at UTC as well. And so she is a trained and licensed physician's assistant and has a lot of experience in clinical care as it relates to maternal and child health. So Teresa Blackman is going to help us facilitate this conversation so that we can not just state problems, but also state solutions and think about how we can better serve our community. So I will turn it back over to Teresa.
Thank you. So I always like to start with challenge questions, get everyone thinking as we have this discussion to kind of frame our discussion and our thought process. So today's challenge question is, in a society growing divisive, helps if I spell my challenge question correctly, but in a society growing divisive and increasingly combative of diversity, why is it vital that diversity and inclusion be present in healthcare? So that's kind of what we want to explore today. What are the issues that diversity can help alleviate, specifically looking at maternal and infant care, and what are ways that when we are not embracing diversity and not embracing inclusion, can those cause physical harm as well as emotional and societal harm? So with that, let's kind of jump in. I have some sort of stats ready that I can jump into, or if anyone wants to kind of get us started.
I think if you start with your statistics, okay. I think that's a great start.
All right, let me roll a chair here. So let me start here. So we actually went in the US, we have a really, really high maternal mortality rate. It's shockingly high for a country as economically sort of advanced as we are. We do not rank anywhere near our economic sort of equalers. So Germany, the UK, Japan, they have a much better rate than we do, which is not good, because that means that we have the tools and we have the resources to prevent these problems, but we're not doing it. So we actually went 11 years without updated statistics. For the longest time, we were operating on about 19 women per, I think it's 100,000 were losing their lives in maternal experiences. And so what they rate that is someone who passes away either during the actual delivery, or I believe it's within 45 days after delivery, which is kind of considered the postpartum period. And those that are healthcare practitioners can definitely correct me if I am wrong. So we did get some updated statistics. We dropped a little bit. We are now 17.4 maternal deaths per 100,000 live births. So to give you context, in 2018, that was about 658 women lost their lives. That ranks us just behind Russia and just ahead of the Ukraine, to kind of give an example of the countries that we are on par with. But for the African American women, it's much higher. it is, I believe, 29 African American women per 100,000. If I have my statistics correct. So we're looking, nope, sorry, 31. 31.1 deaths per 100,000, according to the latest statistics, are African American women. So it's much higher. And there are a lot of sort of reasons that people think this. There are a lot of factors that are completely outside a woman's health, economic factors, where they live, the kind of care they have access to. And so that kind of jumps into this conversation of equality, inclusion, diversity, why it's important. So those are those are all of the statistics that I have. Let's take it away with some discussion.
Hey guys, my name is sorry, go ahead, Jasmine. You go ahead.
All right. I'm Jasmine. I'm one of the second year MPH students. Thank you for having me on this call. This is an interesting topic, and I actually was gonna go with the statistics you just gave. A couple of days ago, I was reading up on some of those, and I agree. There's no reason why in 2020 the United States should be where it is right now in terms of the maternal morbidities and mortalities that are happening right now. And I believe there was some data that came out last year that said that between the 2007 2016 year, we actually increased from 15% to 17%. So we're making progress in terms of a whole picture in terms of the other countries that are in the same situation economically as us. But in terms of just focusing on our own healthcare status and how we're providing for mothers, there's definitely room for improvement. And I think that starts with being aware and intentional in the healthcare system when it comes to addressing those cultural competencies, and especially in African American women, and as you say, the Latinx population as well. Addressing, there's different things that go into it, whether it's a language barrier, whether it's a socioeconomic barrier, if it's a religious differences, just making sure that people that are on the team working in healthcare are aware of those, and that the leaders that are in charge of those healthcare providers or workers, nurses, whoever it may be, that they're understanding that it's more than, just saying that we represent this, but actually doing and making sure that the people on the team understand that and how to make that happen. So that's, get us started there.
Definitely.
Man, that's hard to come behind. My name is Rosetta. I am also a second year MPH student, and I'm also a clinical researcher by trade. And so Jasmine has hit so much of this information on the head for what we have seen in the research and literature review. So much so that we're actually using our PI course, which is Planning, Implementation, and Evaluation course, to actually examine different barriers that mothers are facing. So not just within the first 45 days, but peripartum, postpartum, out at least to 1 year. The barriers that they're facing, and a lot of those have to do with the maternal health issues that they see right around birth, and it carries. And we're looking at the mental health aspect. So just to step back a little bit with what Jasmine had said, again, that core team that's providing the healthcare to these women, it's not just checking off that box, like she said, as far as cultural competency. You have to be able to present information in a way that they can understand, because there may be terms that are utilized, that we utilize, that culturally may mean something else. And because of either their culture or background, they're not going to ask a question or challenge what you've said, but they walk away with a misunderstanding. The other aspect of that is laying down the biases that you have. So we all come in with something, but in order to provide holistic care to this woman that's coming in to give birth, we have to lay those aside and really actively listen to what she is saying, because there may be different nuances that she's experiencing in her pregnancy that you don't see in the common patient that's coming through, your stereotypical Caucasian female you may not see that in the stressors with socioeconomic status and things of that nature, educational background that they're bringing in. You have to address all of those things in order to give the best possible care to that mother. And I am a mother myself. So there are some things that I know that I experienced personally with both of my children that I know that equal peers did not. And so it just kind of brings home more so the disparities, yes, that you see in healthcare. And if I didn't know to speak up for myself, could I have been a statistic or something had happened to one of my children? So again, we have to think logically about what we're doing, and like Jasmine said, intentionally, so that we're giving them the best care.
Yeah, you bring up a really good point, and I wonder, because we're probably all familiar with the term mommy shaming, but really when we think of it, we think about working women who are being kind of shamed for not being like the super mom that's able to pack the homemade lunches and make the, homemade Halloween costumes. And then, flip side, the women that are staying at home are being shamed for not doing, having careers and whatnot. And I wonder if that mommy shaming can extend to the pregnancy period, where there is either intentional or unintentional shaming of women who don't have access to resources, don't have access to prenatal vitamins, don't have access to consistent care, are being shamed either, overtly or, kind of behind, the side glance of, well, you're not taking your pregnancy seriously, you're not a good mother. And a lot of that is tied up in the color of a woman's skin. Automatically, a practitioner thinking, well, this woman is of color, she's not doing what she needs to do. Obviously, it's not, it's her fault. She's actively causing harm to herself and her child. I don't know, Shannon, since you are practicing or were in healthcare, I didn't know if you had seen that or maybe had some thoughts on that.
So I was going to jump in a little bit. A lot of my experience is with pediatric care, but what we see even from pediatric care is good early prenatal care. And so some of my experience was not getting the prenatal care needed, and that can be for a variety of reasons that Rosie and Jasmine have already touched on, but that access to care, but also some of the cultural interplays with the connection to care. So sometimes the early ultrasounds or the early, prenatal vitamins, things of that sort, the knowledge known kind of culturally, whether or not different groups will access that care or have access to it. So some of the early recognition of birth defects or difficulties with the pregnancy can go missed if the individual does not have that access to early care. And even beyond the access of it, there are some groups where even stepping into a doctor's office can be anxiety provoking. And so whether or not that interplays with the early identification of these issues, so all of that kind of ties back to these biases with providers, and how do we start to introduce those issues to providers to be more accepting of our community of color and speak kind of on this equal basis. And whether that's talking in a language, talking in a language that the individual understands. And that can be even just if your patient speaks Spanish, having some sort of inclusive interpreter, or coming down to health literacy, whether or not the individual that you're speaking to understands what you're saying. Because again, that can then promote the mother to walk around with this misconception of what's going on with the pregnancy. So kind of all of that, from really conception to birth and then postnatally, what all is happening. It's an all-inclusive issue. There's issues at every step along the way that can be addressed and improved upon. So that's what I've seen from a provider. We got to do better all around.
Was someone about to say something beforehand, or possibly I imagined it in my head? And that's kind of the way that we want to bring this discussion around, is how can we inspire folks that are going into healthcare? Our guests definitely chime in, either using the chat or if you want to share your thoughts. How can you approach these bias ideas? How can you maybe explore if you have bias? You know, a lot of people don't walk around thinking, yeah, I'm biased. Like I think this about this group of people and this about this group of people. It's not something that, you know, many of us, there are some people that do, we don't know our bias oftentimes. And so what are ways that we can maybe think about identifying them? So if we're going into healthcare, we can offer a more inclusive experience for patients.
So I might jump out and say that although we don't all walk around saying, oh, I'm biased against this group, I'm biased against that group, there are biases that we all come from. So it's kind of the ignoring of that causes problems. So by saying, I don't see color, or I don't see you as a Hispanic woman, you're taking something away from that individual. That is something that we all see. And by kind of giving that general glaze over of I'm going to treat everyone equally, yes, that's wonderful and beautiful, and we should all strive to get there. But there are biases everywhere. And with those biases can be problems if they're not identified. So I would almost kind of back around that you need to see those, own those, and work on those and be intentional about where your biases were, just based on how you grew up, where you grew up, what kind of previous experiences you've had, to be able to be that better practitioner. Because if you don't know about it, then that is where I think many issues can happen that are unintentional, but yet still detrimental.
Very good point.
Yeah, I completely agree with you, Shannon. Just holding yourself accountable for it. So just as much as we recognize it in other people, recognizing it in ourselves as well. So that time when you're walking down the street and you decide, oh, I don't know about this person, I'm going to cross the street to a different side. Like understanding that you're doing those same things that if someone else did it, you would acknowledge that. So holding ourselves accountable for it and recognizing those. And then even when you're talking like in a team setting, because healthcare is all about collaboration, working together, even in a team setting, setting that environment where it's okay for people to point out if they notice someone else doing something that's not necessarily good. And if when they're put in the situation as a practitioner and they did that same thing, it could result in some kind of illness not being treated, or a death possibly in a patient because of those biases that weren't addressed in a team setting. So, yeah.
100%, just jumping more into the team, making sure that within that workplace you do have that collaborative safe space that someone can walk in and feel comfortable, and that comes from administration down as well, ensuring that everyone is aware that these are not things that we sweep under the rug, but we actually will step up and address them, and making sure that people understand that when someone says it, they're not coming at you in that negative tone, but they're coming at you in a way of helping you to understand or helping you recognize a bias that you may not have realized was there, and the willingness within that individual, like you said, to say, okay, I may not have understood that or without it being brought to my attention, but now that I am aware, how do I actively work on and foster a more collaborative and understanding and culturally acceptive way of reaching out and touching and treating my patient, so that I don't miss something, just like you said, Jasmine, that could cause them to die, which is something that we have definitely seen. Even, and it doesn't matter what your socioeconomic status is, if I can throw that out there, for some women, because we've seen very high profile African American women that were at great hospitals. I think the one was Cedar Sinai, maybe it was, that she still passed away. This was a woman of means. The family was very prominent, and she still died. So it's just got to transcend all those different things to make sure that it is, I think of a good way to put that, just to make sure that it reaches and does what it's supposed to do.
And it's challenging. It's scary to think about challenging bias when you see it. be it if you see it in yourself or you see it in someone else. And so I can't remember if it was one of our previous diversity discussions or it was another event, but this, I know it was this semester, I had a student say, well, how, because they wanted to be a physician, what do I do? Like, if I see someone that I work with, moving forward with a bias that I can see is wrong, like, what do I do? How do I address that? And so I didn't know what sort of advice or thoughts that you guys would have. And again, our guests, if you guys want to jump in about ways that you think you would want to address that in a kind of workplace medical field.
So one thing that I'll touch on is even as providers, practitioners today, there are misconceptions and misinformation about many communities. And so you will have older providers who have been taught that there are differences with communities. We can use the Black community, for example. There are research papers that document that there are differences between a white person and a Black person. And people have been taught for many generations that this is true and that this is verified. Now it's being misproven. However, the previous practitioners were trained under that. So what I have encountered in clinical practice was that I had nurses that I was working with that had misconceptions and misinformations that had been carried on for years. And I flat out addressed it and introduced that was inaccurate and then sent information to these nurses that had been in work for 60 years, that here is the information that is current, and here is the information that disproves what was previously proven, and here is how we should process forward. So almost the way that I identified and jumped in front of or kind of challenged that information was with new and more current information. And yes, it's sort of like my numbers are better than your numbers, but it's still, here's the information that was wrong. It was introduced to you previously in this manner, in this light. However, here is the new information. Here's how you're doing harm. So kind of coming back to the individual, back to the person, back to the patient. Here's how we do no harm. Here's how we continue with our information. And one thing about being in the medical field is that it is an ever evolving and ever learning field. So individuals who are scared of that or timid or kind of shy away from it, not that they shouldn't go into the medical field, but that they should recognize why they are timid or afraid to continue to learn, because that's something, as medicine evolves, as information comes out, we have to do for our patients, or else we're doing harm. I think that it's something that you're a forever learner, and you need to kind of own that to be in the medical field.
Can I add from the research perspective? For me, I have to be able to read my audience, and it depends on the relationship that I have with that person. So if it's a colleague and I've worked with them, then I have no problem jumping in to say, listen, that's incorrect, just like Shannon does. And here's the information. For others, it is a little bit more challenging, because if they look at me as an African-American female and I may be challenging a Caucasian female or male, particularly because the medical providers that I work with, then I have to choose another route that's going to get the same results. So, excuse me, I may have to go to one of my nurse practitioners who happens to be Caucasian and say, listen, this is what I noticed. I know your rapport with them. Do you think that you can address this? And then, of course, they'll have me in that space. So then as the conversation is brought up, they're bringing it forward, and I'm basically co-signing behind saying, yes, this is either what it is or what it should be. Sometimes that's a lot more effective than me trying to pull someone aside, especially if they're my superior, and saying, hey, I noticed that you may have treated this person or said something, or you said that person, and they did not really accept that. So I just had to choose a different route, same endpoint.
And that's a wonderful statement or point that does it comes back to privilege. And so talking to Rosie, or, about how her means of going about it are different, that's something that I need to take into account, that those that come to me that can then ask me to advocate for them, it's very important for me to have opening, listening ears and heart and mind, because something that I might be able to walk up and say is not the same or is not interpreted the same way from somebody else. So I need to be aware and cognizant of that to be able to advocate for people around me as well. So thank you, Rosie, for bringing that up, because that's very important.
Yeah. And again, that's one of the objectives of our series, is to really inspire those of you that are going into the healthcare field to not only be advocates for your patients, but be advocates for each other. You may have the ability or the platform to do something or say something or stop something that others cannot, and really move forward title, move forward this idea of diversity and inclusion being a core, it should be something we champion in healthcare. This is a really good conversation on bias. There are, of course, other things that we want to discuss, but I don't want to cut us short. So just kind of thinking as we move into other areas, are there other sort of thoughts about bias that we want to explore? So I want to take advantage of the fact that we have a wide sort of resource of public health minded folks with us today, and kind of explore, going back to kind of our topic of maternal and infant mortality, kind of the nuts and bolts of what things cause that, what factors cause that, because the WHO has ranked maternal mortality rate as sort of a sustainable development goal thing, to kind of to rein that statistic and to keep women from dying during childbirth and to keep children alive as something that globally they are committed to eradicating, which is very cool. And they have sort of listed out some things that are preventative, because I believe 2/3 of maternal mortality is preventable. And so looking at these things that we can prevent, so the WHO, which is the World Health Organization, has sort of ranked some factors that prevent women from receiving or seeking care during pregnancy and childbirth that can lead to serious illness, injury, and death. And that's poverty, distance to facilities, lack of information, inadequate and poor quality services, and cultural beliefs and practices, which we've kind of touched on all of these. But what's interesting is when they talk about this in their report, they are talking about women in remote areas, regions with low numbers of skilled healthcare workers, such as Sub-Saharan Africa and South Asia. And so again, going back to our challenge question of thinking about, why it's vital that diversity and inclusion be present in healthcare, thinking about the fact that in the US, we have such a high maternal mortality rate, but we have a World Health Organization saying the factors that cause many women to die in childbirth are lack of skilled healthcare workers. Well, we know that's not the case in the US. And looking at all these factors, kind of let's talk about, from a public health perspective, how we are dealing with those factors in the US, and just kind of unpacking that information a little bit. So I will turn it over to our group to start discussion.
So one thing that I will say about the skilled healthcare professionals, we still have areas of need of skilled health professionals. So even though we aren't an area that you need to travel days for, if you're talking about immediate care for some sort of prenatal or postnatal issue, or access to appropriate care for pediatrics, we still have I'm forgetting the exact word of it. That's all. But we still have areas that need skilled health professionals. So we have areas that there are too many, and we could kick a whole lot of them out. But we have a whole lot that we don't have appropriate access to those individuals too. So you kind of have this weird bifurcation of needs where you have too much in one place but not enough in another. So I think that's something that could still be addressed, and we're trying to address that with public health service core, things of that sort, but you're still needing more and more providers in certain areas that they aren't. So still lack of providers for the US.
I think to kind of piggyback off of that, it also comes to like an allocation of the resources that we do have available, whether it's providers or whether it's in the actual like hospital setting, as far as when two patients come in with the same symptoms or needing the same procedures, how is it determined who's going to receive that treatment first or who's going to be in the waiting room still? So I think that's a factor that still has to be looked at when discussing how we improve in healthcare, even with us having enough of the per se skilled workers available to us. So
And to
I
bring it
think
kind
it's
of
also
to a,
important.
oh, go ahead.
Oh, sorry, and I apologize because I know my responses are delayed by
No,
my
you're
connection, but
go ahead.
on the other spectrum of that, for the women that are going into care, you know, again, it highlights the importance of diversity because you need to see someone that looks like you. So therefore, it establishes a level of trust when you're going in. You're going to listen to what they say and believe them because of it could be shared cultural, racial connections. That person's looking out for my best interest more so. Also, as far as health literacy, again, in the community, you have to, in order to do something you've never done, you have to be exposed to that. So it could be that they've received negative information from sisters and cousins about the care that they received when they went into the hospital. So again, they're unwilling to go. So those are kind of two things from a patient facing standpoint that we have to address from a public health standpoint as well, like education and letting them see someone like them there that may help to drive in and change the numbers that we're seeing for the disparities in mental health. I'm not mental health, excuse me, maternal health as well.
Very good point. And we see a lot of this playing out in current events. You know, the census, there's a lot hot debate around the census with it not being accurate and not counting appropriately. The census is huge in allocating resources. And when communities of color, underserved communities are not properly counted, they are not able to access or be given access to appropriate resources. And so that's where we see this sort of mismatch of resources. We have suburban communities that have, you know, the greatest, most wonderful things. And, you know, you can't turn around without seeing a doctor's office or some sort of healthcare office. But in other areas, you have to travel incredibly far to find any sort of like walk-in clinic, let alone a doctor's office or a facility that could handle, you know, serious medical issues. And so there's a political aspect to this, and there's a very deep-seated historical issue with communities of color not being given appropriate resources that kind of stem back to segregation and this whole idea of separate but equal, when we all know it's not equal. And we still see that in society today. So there's so much wrapped up in this idea of appropriate resources that it causes us to have to be engaged not only in healthcare, but also in current events and politics, as much as we may not want to be. I don't know, what other thoughts do people have, insights or things that we want to discuss surrounding this idea of access to care?
I was interested in like the spirituality part because you guys had mentioned how like spiritual beliefs or like religion affects that, and I was just curious about like I have an idea, but I don't really like I can't like narrow it down.
Yeah, for sure. Shannon, I don't know if you had an experience that you wanted to share, or maybe some ideas of some spirituality that may play into it. Putting you on the spot.
No, that's just fine. I'm trying to draw from my past experience as a provider on specific barriers with spirituality and provider to patients. I don't know that I have a perfect example or a perfect area of that to really speak on. I know that it can definitely cause discourse if there is a spiritual individual on either side and not one on the other. And I have run into that. Maybe primarily with prayer around difficult times. And there are providers that will not participate in prayer with patients. And I do believe that that causes a difficulty between the provider and the patient, and many times mistrust. And so that would be something that as I kind of talked about with the provider that this was specific with, there's sometimes things you have to do as a provider that kind of challenge your own beliefs and ideas. And so in that moment, it's really what's best for the patient and the best building that rapport with the patient. So even though you might not be a spiritual individual, if your patient is, it's something that you need to come to their level on and kind of be with them at that level. But I don't know of a whole lot of other examples of spirituality playing into kind of the lack of care, access to care, other than that, sort of the distrust between the two.
There are certain, I believe it's the Jehovah Witness. There is a sect of sort of Christianity that does not believe in sort of vaccines and blood transfusions and things of that nature, which can cause serious issues if there is bleeding or any sort of need for a transfusion during delivery.
And we had that with some of our pediatric patients. And it was, we actually spoke to the pastor that came in on as a representative of the family. And it was, if the child was either going to die or needed a blood transfusion, then that would be the opportunity that we would give the child a blood transfusion. It kind of comes down to if the individual is incapacitated or not able to make sound medical judgment, then that's a time that a provider will step in. But if it's very clearly said that the patient does not want blood transfusions in any capacity, then we have to respect that. So I know that we changed parameters for that patient on when we would transfuse, because in medicine, numbers are all that we go on. We love them. And so at that number of what the hemoglobin or the blood level would be that we would normally transfuse for, we allowed that to be lower and at a more life-threatening level for the patient based on their beliefs. So that's a good point to bring up. I had forgotten that we kind of met in the middle with the family about that. To my knowledge, I actually don't think that patient needed a transfusion after all, that we allowed the numbers to go lower but never transfused.
In another instance, I know that this is common with polygamist fundamental Mormons, but other more very, very conservative evangelical groups are also this way. Home birth is a big thing for a lot of religions, especially I weirdly know a lot about fundamentalist Mormons. I don't, but especially in Utah, they will not go to the hospital because of fear of discovery, because it is still illegal and their families can be arrested and separated. So there are a lot of issues with home births going terribly, terribly wrong when that person should have sought medical care much earlier, but didn't for fear of discovery. But then there are also a lot of evangelical sects that believe, home birth and whatnot, and they have home births when they ought not to for medical reasons. And so those are some other areas that could cause some harm based on, religion and spirituality, and not here saying either is right or wrong, just that's what happens.
So I have a thought as well from a patient standpoint, not really harping on abortion, but for children that are that come out with like severe birth defects. I know that's probably one of them as well. I know personally with my daughter, it caused me to stop seeing the OB at the time because the way that she presented the information is like, well, if you wouldn't have an abortion for this and you wouldn't have an abortion for that. And for me and my religious beliefs, like that's not something that I would do, but it ultimately caused me to leave that practice. So that would be another area that I could think of if there are severe birth defects, or even if it's puts the mother at risk for passing in order to carry that child to term. That would be another area in which your religious belief would affect the care that you're provided or can be provided.
I have a question. As a
Yeah.
provider, in your opinion, how would you best present that type of information to a patient? Like you said, in your personal experience, it made you leave that provider, but as a provider, they also have to like give you all the options, right? So how do you put it in a manner that's not offensive and that's just neutral in general?
I think for me personally, if it had been presented another way, then it would have been received better. It was very flippant at the way that it was thrown out. And for me, like it was never a question as to whether or not that's something I would consider. It was the way that it was presented that made me concerned and fearful for my own child. But as a provider, I think that for me, I would give that patient as much information because I'm a detail oriented person. So I want to know all the background. So I present that in a manner to that patient as much as they can chew on at that moment, and then allow them to tell me how they would like to proceed. You can ask me my expert opinion on that, and I'll give that to you. But ultimately, that decision is coming from the parent unless there's a life threatening issue or they're not capable of making that determination. Or and Shannon, you'd probably have to step in for that. If there's something that's going on that the doctor legally can and will step in, where you feel like that person's not making the best decision, maybe you feel like mental health is an issue in that instance. So, but that's me. And that's how I even go about it with research aspect when I'm presenting trials to patients. It's always in a manner that they can understand, a manner that they can chew on with as much time. And then I let them tell me what they'd like to do.
So Rosie brought up a lot of good points. The first thing I will say that I've learned in practice is it's very important to tell your patients, unless you have gone through it, that you really don't know what they're going through. So if I was in a room with Rosie and we were going through information about ultrasounds, I would say, first and foremost, I have not gone through something like this. So you need to allow me, tell me how we should proceed forward. Are you a person that likes a lot of information? Are you a person that likes little information? And what information can we talk about? So again, it's not me making this decision. We are a team. It's you and me. And here is some of the information that I have to present to you. Now, this is not a decision that needs to happen now, today. You know, we can talk about timelines. We can talk about that sort of thing, but kind of very honestly, I'm a transparent person in general, but just sort of, you know, I have not been through this before, and let's navigate this together, how you need to navigate this. And so kind of by coming at that from sort of a, you know, I'm here for you, but this is an experience that I'm not going to tell you how to do it. I'm not going to, you know, tell you I know how to do it. Just sort of a general, let's talk about it. Let's start with some of the information. You will have people that want to know every last detail. And many times as a provider, you have to say, we don't know, you know, if it's a genetic problem, maybe this is the best information we have. If it is, and then you can try and work with timeframes. A lot of times with prenatal care, there's this 23, 24 weeks where we talk about viability. And before that, it's something that you need to focus on the mother, because the mother, if the baby comes before 22 weeks, it's not viable. The baby cannot survive. Even with our modern medicine, I think the earliest that I have seen babies survive is 22 weeks. So you have to talk to the mother about that. You know, this is something that the baby at this point won't survive, so we need to focus on you. And then once you come to that 22, 23 weeks, it becomes a little bit more difficult. And again, it goes back to the family. If the family has a religious belief, if this family feels very strongly that this is how it should, that this is how the pregnancy should proceed or not proceed, none of that I come into this with no judgment. I'm not in their shoes. I am not making this decision. I'm also not going to be the one that's going to raise the child with these conditions. And I'm not going to be the one that's going to live with the decisions of not continuing the pregnancy. So you have to remember kind of the fallout of what your counseling of the individual comes, sort of happens from. And I think that as providers, we don't always think about that, right? Many providers will say, nope, this baby's going to have this and this, and you need to do this. And that's not always the place of a provider. A provider is to offer information and support and then to work through it with the individual. So I don't think that there's a crystal clear book, but come at it. If you haven't been through it, be transparent. Say, I haven't been through it. Let's talk about some information. And then you take the patient by patient, everyone's an individual, and ask them how they would want to or need to receive the information. So that would be my best stab at things.
It's a good stab.
Can I just add to that?
Of course.
So like how you're saying about the provider talking with the individual about how much information they want. I think another factor is like if we already kind of touched on it before, but if they're able to understand that information. I've actually worked as a patient care technician for a private OBGYN office, and oftentimes there's adolescents that come into the office and they don't necessarily understand the terminology that's being used, and so they don't know how to make an informed decision regarding their health, or if they're pregnant, their child's health. So I think being able as a provider to, I guess, acknowledge your own emotional intelligence appearing and making use of that intelligence and understanding that maybe this person isn't understanding what I'm saying, and then connecting them with another individual that can give them the necessary information to make an informed decision is important as well. So.
It's a great point. And I would almost recommend to anyone going into healthcare to explore one of these sort of like personality strengths tests. I know I can't remember what the big one that all the counselors take, but I know in graduate school, we took the Strengths Finder, which is really insightful, and it sort of ranks all of these strengths, and it sort of explains, okay, your strength is context and this is how it plays out. And it's scarily accurate. And I know this kind of seems off topic, but as you're moving towards a career where you're going to have a lot of difficult decisions and you're going to have a lot of conversations where you have to straddle that line of being empathetic and analytical, understanding yourself is going to be really important. And understanding, if you know yourself to be someone that wants to tell people all the things, like I want to tell you all the things, knowing that about myself and being able to understand, as Jasmine pointed out, like, it's not the time to tell all the things. This is not someone that can understand or process all the things, and that's not going to be helpful. I think will make you a really good provider and help you sort of be kind of all things to all different types of patients, because you know yourself, and you'll be able to then tailor your responses and your reactions based on what your patient needs. So, plug for personality tests.
To also speak to what Jasmine was saying, I think it's really important to meet your patient where they're at. I always hate the come down to the whatever level or come up to that level. You are who you are, but make sure that who your patient is, you're meeting them there. So it's not really like an up or down, it's just common ground. And then find that common ground to be able to tackle this medical problem, or to be able to be on a team together to work forward for whatever the problem is. So, and then speak to their level, speak to their information. No, not everyone has access to go to medical school or to have any kind of formal training. So you should be able to explain the issues that you're going to encounter in whatever field of medicine you're going to go into at the simplest level. And then as people can and want to hear more information, be able to give that. But you're not going to be an effective provider if you can't speak to the level of your community or speak to the level of your patients. They're going to miss a lot of information. You're going to miss a lot of care and improvement that they could have.
Absolutely. Any other questions or thoughts about this? Good discussion, guys. So kind of again, moving along the thread, because we have our public health friends that do lots of research and are looking at ways to keep the community healthy. One of the things that they sort of identify is ways to kind of help. Okay, so we've identified, okay, these are the problems. All right, well, we could talk about the problems all day, but how do we fix it? What do we do? And so some suggestions have been to kind of better understand and address disparities. Providers could increase screening for social determinants of health. So things like levels of stress, trauma, food insecurity, neighborhood violence, access to prenatal care. These are all things that contribute to disparities and warrant further investigation. So as providers, are there ways to screen for these? You know, what do you all think? What possible solutions would you have, or research have you come across?
So I will say that you can always screen for them, but it's kind of like the survey. Don't give a survey unless you're going to do something about it. So I think that, yes, it's important to identify, but as public health professionals and providers, what are we going to do with that information? So if you are screening for these certain things, how is it going to improve the care that you give your patients? So, and that might be something for, I don't know, Jasmine or Rosie to talk a little bit about. If you identify them, then what do you do with, from a public health hat, what do you do with it? How do you improve it? How do you better those identifications?
So I think if we're going to screen for it, and that's probably something that we're doing in our research that we're doing with PI, is that you have to already have some partnerships in place, some referral information that you can provide to that individual so that they can seek the help that they need if you are not capable of doing that for them. So maybe if they're coming for medical need, but you can't do mental health services, there may be other resources within the community that they can go and utilize. And it may not be at a crazy expense, or could, like I said, partnerships where they can go get the help that they need. So that for me, it's about establishing partnerships, resources, and having those readily available to provide to that patient. And then you need to follow up with them, right? If we're going to do whole care, you need to not only give it, but you need to follow up and make sure that it's been utilized, or set it up for them in advance so that they can go. I think that kind of falls under the holistic type of care, or the whole patient model, something like that. I might be saying it wrong, Shannon. But to make sure that it's actually utilized and it's beneficial for the patient, because that in and of itself will improve the patient's outcome.
Absolutely.
I agree, Rosetta. A little bit more context on like our course and research that we're doing right now. So we actually started out with this idea. We wanted to focus on mental health and mothers, and we went in with it thinking, all right, we can go to a pediatrician. They're going to see the mothers, all the time because they're bringing in their newborns. And so we went that route, but after speaking with the pediatrician himself, it was brought to our attention that the issue isn't necessarily rooted in who they see, because the pediatrician, their focus is the child and not necessarily the mother. So they're screening for these stressors and things that are associated with the mother as a result of having given birth and before giving birth. But that's not their area of focus. So they get that data, but they're not necessarily doing anything with it. And then our next question was, okay, well, since you can't do anything with it, what do you tell the mothers? Like, what do they do then? And so it's basically like making sure that they have the resources available to refer that mother somewhere else in the community to address if they do have some kind, like they're developing postpartum depression per se. So making sure that when you again have that data, what do you do with it? Because in their sense, they're not doing anything with that data. It's just there. It's just a number that they have to say, yeah, this person has this or this person has that. So yeah, making sure that there is somewhere that you can refer someone based on the data that you do get, even if you're not the one that's analyzing that data, that you can send it somewhere to have something done with it.
Absolutely. And Jasmine, it's such an interesting point because so personal share, but I have two small kids and I was off the chart on postpartum anxiety and depression both times. And never once did the pediatrician connect me to any care. And never once did my OB connect me to any care. And for whatever reason, who knows? I mean, it is what it is, but I was the one that had to seek personal care on my own, even though on every single chart I would open up my kids, it would say mother is positive for postpartum anxiety and depression, mother is positive, and patient is positive for this and will refer. I never once had a referral from either one. So it's information. And it's also, I have no idea why they wouldn't have just said like, girl, you're going a little crazy here. Like, here's some information. It's an easy one step. Here's a paper of providers, or here's a paper that, we can connect you with this, but you ask the questions, then what's the follow-up? Because if anything would have happened, thank goodness it didn't, but if anything would have happened, everything said that I was a positive screen for it, but there was no connection. So that's a really important step, and it's easy. So make that closed loop to continue to actually get the care for the individuals that need it. Because it's not always a perfect cookie cutter, I'm supposed to have all the issues. So everyone's a little bit different, and it's important to make sure that your patient is getting care. It's not just about the baby. It's not just about the mom.
Do you think that sometimes we're putting a little bit too much pressure on doctors in that way? Because the goal is to see if we can, so we're like doing an assessment to check to see, right? Which can be done by pretty much anyone. But if you did an assessment and you got the information before by, say, like a patient care technician who got the information and collected it, you could have social workers or counselors come in and do a deeper assessment so that the doctor wouldn't have to worry about that and you had caught the problem before it even happened.
And so they're pre-printed. I should know the name of the assessments. There's 3 or 4 of them that you take at the certain intervals when you come in with your child. I wouldn't have even needed a doctor to address that with me. It could have easily been a patient care technician that handed me a list of names and resources, and said just clearly, hey, you are positive on this. We would encourage you to talk to somebody. But that was, so I don't even think the ownership necessarily is on the doctor. Maybe it could be a sidebar of, I see this was positive, our patient care technician, whatever. Or somebody will come in as the baby's getting shots to give you more information. I would encourage you to follow up. That's 3 seconds. And I don't think that that's too much to put on a provider.
Ethan, you bring up a really good point, because think about underserved communities. So maybe a rural community where there's one doctor. So then it is the responsibility of the provider in a way, because there is no one else. Or in an urban community where there is only maybe a walk-in clinic or a pop-up clinic, or a Planned Parenthood that is currently trying to be defunded for like the 80,000th time. That I think segues perfectly into this idea of inclusive care, because we want to be able to provide, the provider with the resources to help the patients just as much as we want to help the patients. And there's that disparity, there's that inequality of care. And Shannon, is an educated healthcare provider, and was able to, help herself in a way, but not everyone has that resource. So it's, again, something to think of. And Rosie, I totally cut you off, and I'm so sorry.
No, you didn't at all. I was just thinking for Ethan's statement is just to add that if the provider is going to ask the questions, because sometimes it's a checkbox for insurance purposes, right? Your visit doesn't get reimbursed unless you've met every portion or requirement for the insurance company. So if they can complete that checkbox in order to make sure that they're properly reimbursed back, then closing the loop, as Shannon said, would be to ensure that either they're sending them to someone, or if they're going to utilize social services or a caseworker, that person is readily available, because it may not help that mother to leave that visit and then someone may or may not be able to reach them 2, 3, 4, 5 days later. If you're going to identify that there's a positive screen at that point, they need to be available, readily available to discuss with that patient, then at least contact And if it cannot occur at that point, at least the patient's made face-to-face and they can move forward on the back end. So that would just kind of be my 2 cents for that.
And I will also say, Teresa, I might be educated and a medical provider, but it took my best friend to say, you're going crazy. Like, you need to go and see somebody. And then that's when I went back through all of the visits and saw that I was off the charts on all of them. So it wasn't even self-identification. Of course, once you like hear that from somebody else, you're like, oh yeah. But I mean, it doesn't have to do when you are in mom stage. Nothing really makes sense. Personally, I mean, other people might excel at it and do great, but I was drowning and I couldn't even identify it. So it's something that we really need to, as a community and as a society, take care of these new mothers, because it's, man, I could read all the books I wanted to, and I could go to all of the classes and do all the things, and I was still wildly unprepared. So just some information.
Yeah, that's a good point. And then, circling back earlier, Ethan, on your question about spirituality, this is also a big component. There are areas of faith that don't recognize mental health issues, that, pray about it. And so that is another layer of challenge as a provider, as an advocate. What do you do when your patient is saying, well, my family says I just need to pray about it. And obviously, that's, not to say prayer doesn't work, not to suggest, someone's beliefs aren't valid, but knowing what we know about, postpartum depression and anxiety, a little more needs to happen in that realm. So it's a sticky challenge.
So prayer definitely works. We've proven that. There's documented research of it. But a chemical imbalance in your brain can be helped by medication. And so helping that chemical imbalance, or helping, just bridging the gap for a moment as your hormones have changed and your not receptors, but your whatever chemicals in your brain have changed. There are medications to help with that. So although prayer, yes, is very, very important and can do a lot of change and good, sometimes there still needs to be medical intervention. So kind of spirituality with medicine.
Yeah. Other thoughts or questions?
I have a thought to throw out there.
Yes.
And it's really centers around providers. As Shannon knows, I mean, sometimes by the time you get your patient back, especially if it's primary care, you might have 15 minutes if you're lucky, especially when patients are scheduled every 15 minutes on your schedule from 8 to 5 p.m. So in order to help better outcomes, particularly maternal health outcomes, we need to give providers more time to be providers, where they actually have time to read the patient's chart, talk with the patient, really sit down and assess what they're hearing and what the patient is saying, and then moving forward with a holistic care plan for that patient. And so that would be something that I know I would personally love to see them push. I don't know if it's legislation, whether it's doing something with reimbursements from insurance companies or whatever have you, to ensure that we can let providers be providers again. And they're not just basically like this meal where they're churning patients in and churning them out, but they can actually give the care that's necessary.
So a lot of that comes down to insurance companies and reimbursement amounts and, et cetera, being able to pay the bottom dollar, all of that. But I think that is incredibly important to be able to take more of that time, especially if you're talking primary care, because you have older adults that are coming in with, this doesn't have maternal and child health, but older adults, you have a laundry list of issues with a laundry list of medications. How are you going to be an effective provider? By looking through all of that in 15 minutes, writing a note, fulfilling prescriptions, and doing a physical exam. So it becomes very, very difficult.
How do you think that we can fix that specific problem? Because I used to work at Walgreens as a pharmacy technician, and that happened a lot. And we were really putting patients at risk by the ratios, like just the ratios where we were messing up. Like the pharmacists weren't catching tech mistakes, techs weren't catching pharmacist mistakes because we just had too many patients and they were turning it like we are always going. And it was a money thing because we weren't going to tell someone, no, go to the Walgreens down the road or go to CVS because they want their money. They want their insurance back.
I would say it starts with legislation, but it also has to do with insurance companies and advocating to them for the provider. I mean, it's really, unfortunately, a very broken system. I don't want to be a Debbie Downer and tear, but that's sort of like the huge mountain of how you overcome all of those issues. And as public health professionals, we see little areas that we can help in, but the overarching issue is that our medical system is broken. And there are many more broken aspects of it, right? Like our maternal and child health aspects is quite broken. And then you also have your provider time is broken. And so all of it, but this little subsection, I think that there can be a lot of good and help happen if we really start to address some of these issues. As Teresa brought up, there's multiple different issues that are causing this high mortality rate in the US. So we have kind of this pointed thing that we can start to work on. And so I think that sort of not becoming overwhelmed by the whole mountain in front of us of the healthcare problem, but looking at specific areas that we can help with and improve are important.
Shannon, can I also add, one of the providers I work for is very out of the box, and it was something that I've never heard of before. But just in light of our conversation and things we've been seeing, especially highlighted with COVID, right? It really makes a lot of sense. And so this proponent is that we let providers be providers again. And so he's effectively got this co-op of providers that have come together, and they don't do insurance at all, but they let patients come in and basically pay like a membership, an affordable membership, right? And for that, and I think it's $75 a month, they get all the time that they need with that provider. They have any emergency visits they need with that provider, all of their, if it's a primary care issue, then they are able to fulfill that with a provider. So that's very radical, and that's very out of the box. But if we have grass movements like that, you get enough of them going, then you can really put pressure on the insurance companies to mandate change, because insurance initially wasn't being utilized the way it's being utilized now. And because of that, the burden of utilization is outrageous. And why they have to keep coming back for multiple visits for the same type of issue, because they couldn't address it the first 2 times they came for their visit and the follow-up visit. So that is something very out of the box, but again, it puts pressure back on the insurance companies, but also we can focus on the aspects that are contributing to the brokenness and to the disparities that different patients are facing when they're going in to seek their treatment. So.
I was gonna say, Rosetta, you kind of hit the nail on the head there. As far as being in COVID times, pandemic right now, I think it's forced many providers, insurance companies as well, to kind of focus on this issue. So when we think about now, there being telehealth appointments, Zoom appointments, FaceTime appointments, people going to the hospital and having to do that virtually. And I think the Centers for Medicare and Medicaid Services, they actually propose a plan now. I'm not sure how long it's going to last, but for reimbursing companies that are using these services right now during the pandemic. So I feel like that it's making us more making it where we have to focus on this issue of managing the time of the doctors and actually having a patient to physician conversation time allotment. And so once we do get through the pandemic, I feel like it'll be more on the forefront of us focusing more on that issue and maybe making it more of a pertinent thing to focus on, and changing the way that funding goes, but providing for those resources and types of innovative thinking going on. So.
Rosie, one of my thoughts when you talk about kind of this radical change is this almost makes kind of our bifurcation of needs and access more, because you now have a group that can pay for their time with their provider. They are getting better health. And you're only going to have so many patients that provider is going to see that aren't paying anything, right? You're not going to have a provider that says, I'm doing all of this because I'm a good person. I'm not going to have an income. And I know that these people can't, you might, but these people can't pay. So that it really almost divides us. Now, I think it does push on the insurance company, but it almost divides even more so because you are putting kind of a finite number on those that can have that care that can't pay. So just something to kind of flip of the coin, think of. The other side of it is that not everyone's going to be able to have that care.
I mean, I think that's a challenge that's, I think, one of the biggest challenges that we face in this country is not everybody has equal care. Not everybody has the same access. If you are in New York during the height of the pandemic, your ability to go to the doctor, to the hospital was severely limited. But in Chattanooga during the same time frame, I know from experience, unfortunately, I had to leave my husband at the ER. He had severe double lobe pneumonia in late March, early April, and he was seen immediately. We have a cousin that's a physician's assistant in Houston, and he was saying, like, this is the perfect time for your husband to be sick because all of the medicines were there. He was able to be given, 3 intravenous and antibiotics within like a 3-hour period. And it was rapid fire. He's like, I wasn't alone. Like there was always 2 or 3 people in there, like trying to figure out what was going on and get it fixed. His experience far different than someone who had the same symptoms in a larger city or a place that was going through a spike of COVID. And so that's the struggle. Any other thoughts or questions on that? We kind of segued into talking about COVID a little bit, which was on the agenda to chat about if we wanted to kind of move over in that direction, or if some of our guests have questions that this discussion has brought up, we definitely welcome those. Ethan, did you have a question or?
I didn't. I was just looking through my notes.
Okay, no worries. So, I mean, this is kind of it seems like a radical segue, but we did start talking about COVID. And one of the things that, I think is important is to kind of think about inclusion, diversity, and how pandemic treatment is happening, both in our area and in, the nation, as well as we're doing with that. Do what you will with that statement. But yeah, from our guests or from our panelists, like what are some areas maybe that you've seen in research or that you've noticed about, COVID treatment and diversity and inclusion and all that fun stuff? It's an easy question, right? No big deal.
Right. Shannon, feel free to jump in. So I, as a clinical researcher, I do research on COVID. So right now I look at testing and not treatments. Stepping away from that aspect of it, just doing literature review, you can see that a lot of Black and Brown individuals are adversely, like the representation for Black and Brown persons is tremendously higher than it should be as far as sickness and death and related to COVID. And the care, the level of treatment that these individuals receive is not the same as their Caucasian or Asian counterparts. So we're seeing that overrepresentation in these communities off the board, or across the board rather. And then as far as from what I have seen in research, just the knowledge base of what people know about COVID, whether it's transmission, whether it's even understanding or comprehending being in isolation, because the way that I present it to some people that come back and are testing positive is very different depending on their level of education, where their fear levels are. There are patients I've had to stop them from crying. I'm like, stop and breathe. You're okay. And that's adults and telling parents that their 3-year-old child is COVID positive and they have no sign or symptom whatsoever. So from the literature review, it's very disproportionate. From a personal view of seeing the patients that come in that we test across the 2 different methods, is also very different in the level of education and understanding that they have.
So I think even before COVID, providers would minimize and dismiss many community symptoms. And I think that now, when we are in a pandemic and we have a lot of sick and ill patients, that problem is worse. And I mean, it's well documented that there are new providers. So I was talking, people that graduated 60 years ago, they got misinformation. Well, even new providers, even new doctors, even new PAs or NPs coming into the field have a misunderstanding or a misconception of symptomatology of diverse communities, presentations. And so now that we have an actual issue where people are needing more immediate and appropriate care upfront, it just exacerbates the issue. And so I think that as a medical society, we're starting to see more and more how our biases or how our misconceptions are hurting our patients. And so I would attribute to a lot of what Rosie was talking about with the literature, that it's appropriate, quick, and effective access to care for all communities. And we're not having that. And that is also the issue that we have with maternal and child health. Just that lack of appropriate, immediate, effective care is not something that's universal to everybody. And there's many of reasons, but it's something that you first have to identify the problem and then make steps to change it. And so I just think that right now what we're seeing is this incredible disparity of how we treat one patient versus the next, even though they're presenting with the same symptoms, or even though they're presenting with the same disabilities, abilities, whatever, we're just not treating them the same. And why is that? And so I think that we have to start, we've recognized the problem. Now we have to figure out the why, and we have to figure out the change. So COVID just made everyone very ugly.
Definitely. And it's interesting, like this start of conversation, our first event of the semester focused on the historical context behind a lot of this disparity in care. And Dr. Kaminsky, who is one of our history faculty, who has also a public health degree and is a medical historian, was sharing things like the oximeter that we use is actually biased against Black and brown people because of the way that the light emits through the skin and tracks O2 levels. It registers lower for folks with darker complexions. So Black and brown patients that were going to the hospital that had a very low O2 rate, where a Caucasian person would immediately have been put on oxygen, that Black or brown patient was not registering the same and then was not put on oxygen, causing them to have a lot more issues in trying to recover or deal with the other symptoms of COVID. So it's not just the humans that are causing this problem. It's the devices that we use are calibrated wrong. And if you missed that one and you want to see it, we actually have it recorded, so you can go to our YouTube channel and check that out. It's really interesting. I never would have thought like a little machine would be quite so discriminatory. Any other thoughts or questions about things?
I had a question about that. I remember that discussion, but I was wondering, like, once we recognize that this is a problem, how easy would it be to like implement a change or something that's like more inclusive of everybody? Would providers be willing to like kind of update their own like knowledge base on, oh, this was affecting one specific demographic, I'm gonna change that immediately. Do you think that's like something that we could actually like see in our own time? Or would it just be like something that we could hope we progress in, but like if it doesn't change, it doesn't change?
I totally think that you'll be able to see a change. I think, again, one of it's recognition and identifying the issue. I think at the heart of each provider, there is the do no harm, right? So if you're presenting, this does harm, this is not giving you fair information. So let's say we come up with a pulse oximeter that's not going to be skewed by the pigmentation of your skin. I think that universally providers would use that, especially if they had access to it. Because I do think, kind of like biases, unless it's pointed out or unless you do the education that this is information that's hurting your patient, people don't know it. But once that is brought to the forefront, I think that you would have only a very small percentage that would be resistant of the change. So I think that if there's something that develops that providers would, now that might be my like beautiful view of all of it, but I really, from a provider standpoint, it is do no harm. It is do the best by your patient. So therefore, if there's better tools to be used, I would think that they would.
I agree. I would say, like, as I'm not a provider, but I'm working towards hopefully becoming a provider. As that being your responsibility to staying educated. So I feel like attending conferences, webinars, where you're around other people that are expressing ideas or concerns that you may not think about on an everyday basis. That's where the conversations get started, and that's where eventually there's going to be a collective of people that have that same concern or idea that will eventually work towards changing something in that process so that a better outcome can be achieved.
Can I also add that from a research standpoint, we see a lot of different companies or manufacturers that are looking at different ways to utilize their product, and many of them are becoming aware that there are differences ethnically among individuals that might cause a medication or a device such as the oximeter to work differently. So from that aspect, we are seeing a lot of them that are coming in, and when they design their protocols to be able to implement something after the research portion, they're inclusive of data that would either confirm their suspicions, and if they confirm it, how can they then provide directive or instruction on providers so that they can utilize it in African Americans or Hispanics or Latinx, sorry, or an Asian Americans or whatever have you across the board. And so I see that personally, and it is determined about how I actually either collect samples or process specimens or the types of patients that I can even enroll. So it is starting to get out there more. I'm starting to see it more as a researcher. I've been in this for 16 years. And so it's getting there from my end. It's just a little bit slower.
I think that's the wonderful and terrible time that we live in. Diversity and inclusion is in the forefront for reasons that we wish that it wasn't brought to light the way that it was with the loss of life, but it is here. And so it is encouraging to see that there is change happening. There's more of a conversation happening, even on like the pre-health level. So I'm part of the National Organization for Advising Healthcare Professionals. They have started a diversity advisory board, and its whole purpose is to identify areas where we are lacking in helping underrepresented communities become practitioners. And this, not to say that there was prevention of that before, but this idea that there is a committee and a collective movement to really say, okay, how are we evaluating students for medical school? How are we preparing students for medical school? How are we providing information to students for medical school? And is it equal? Are we doing a disservice to certain groups of people because of how we give the information? So Shannon, I share your optimism. I think that there's change, and I think that the generations that in school now, you guys, that these millennials that we've ruined the world, apologies, as a group are a far more accepting bunch of folks. We embrace diversity more statistically as a generation. So I think we have the opportunity to see change. Maybe that's optimistic. I hope it's not.
All I would back that with is now that we've kind of made these steps towards change, to encourage, to improve them and follow through with them. Because it's one thing to say, oh, we've started this and we've started that, but it needs to be change. It needs to be the forward movement. It can't just be the identification. And then, here's a committee that'll talk about it. It needs to be, here's how this will change. And so I think that as a group, as anybody, as individuals, not as pre-health anything, but we need to promote that for our community and our society, that you can't just allow this discussion to come up and then fade away. It needs to be continued, it needs to be addressed, and it needs to have a plan and movement. So
absolutely. No pressure, guys.
don't change the world. I'm going to do it with you. So
we're going to support you. Do it, help you with it. But yeah. So any final thoughts, any questions? We kind of run through the topics of discussion, and now we just kind of open it up for questions or, thoughts people have had, ideas. Yeah. What do inquiring minds want to know? You have a wealth of expertise here with research and practice and public health, and I know a few things. No, yes, maybe.
I have a consistent problem, and this is like maybe a personal bias. I do not like old people. As in I don't like old white men. I encounter a very consistent problem of wanting to have a conversation with them and them just yelling at me. Guarantee that's a problem that happens to all of you guys. Do you guys have any ideas? Because we're talking about having these conversations, and I would love to have these conversations with a wide variety of people. And I know that I'm a white man, so they're more likely to listen to me, most likely. But I can't seem to get past the any of it, the rest of it, the meaningful part. I don't know if that's delivery or communication, on my part, or
I mean, there's a lot of factors that go into conversations. I think having these kinds of conversations are difficult under the best circumstances. And there's a level of rapport and trust that you have to build before you can call someone out and be like, listen, stop being racist. Or here is your bias. You want to have, a little bit of credence with them to say, I'm not judging you. I'm making an observation. I think sort of the gut reaction, especially in the South, everyone is nice, but not nice. Everyone is oh, bless your heart, but secretly they're but listen. So we deal with that too, of anytime there's any sort of confrontation, Southern folks, I am one, so I can say this, tend to be combative, oh, this is not coming out of a place of I want to help you grow as a human. You are telling me I'm a horrible person that should die. And so when you kind of build a rapport with someone, you can kind of come to them and say, listen, this is kind of what I'm seeing, or this is a conversation I'd like to have. And that gut reaction of angry, shake my fist, yell at you may not be as apparent because they know you are not just trying to yell at them. There's a lot of things. I don't know, there's a lot of factors in, that I think, especially in the area that we live in, that makes this challenging. People don't want to talk about politics and religion because it's so divisive right now. So anytime you talk about anything quasi-political or religious, there is fear there. And to kind of, give you a faith development background, which is kind of what I studied in grad school, there's a process of going through developing your worldview, your faith, your idea. And if you go through that process of, so you have these ideas that you grew up with, then you move through a process of questioning, and then you come out on the other side. Well, the issue is when people hit that point of questioning and they run the other way and be like, no, like I don't want to question at all. They're very insecure in their beliefs. And so they wrap it up in a defense mechanism of, I don't want you to question this because I don't have an answer. You're going to make me question my reality. And that scares me. And so that could be a way that you kind of think through that conversation, is maybe you are having a conversation with someone who never questioned what they believed. And you are asking them to do that. And that's really scary. And so that's kind of a way that you can approach that conversation. Because the questioning is scary to think about, okay, this is what I believe. This is what I grew up in. This is what my parents taught me. This is what my family believes. And then to like wonder, to go through that process of questioning is hard.
Yeah, maybe it's a lack of empathy because, like, to like them, like I wanna be able to understand, but it's hard.
I feel you. Yeah. And I think too, like the generational mindset, there's just a different thought process of how information is understood and digested. You know, we come from a world where, oh, I don't know the answer. Let me Google it. You know, I'm unsure of this. Let me look it up on the internet. Here are 15 people that have opinions on it. Here are 4 articles with citations that have different points of view on it. Let me spend 20 minutes to get 7 sides of the story and figure out what I believe. And we process that information really quickly. And older generations, that's not how they roll. They are not used to that. This is how it is. This is the answer to the question. You don't need to think about it anymore. Don't ask questions. It's just this. Probably get so many sassy comments when we post this on YouTube. That pre-health advisor, she's the worst. But no, I think when you approach any of these conversations, be it provider and patient, friend to friend, you know, coworkers, what have you, trying to come at it, you know, as Shannon alluded to earlier, getting, you know, meeting them where they're at. Like if you're having a conversation with someone who is, you know, hardcore in a certain belief and they have believed this for 40 years, coming at them and saying, hey, this is how you should think about this, that's not going to go well. But trying to understand them and get on their level and understand, okay, why do you think this? How did you come to this conclusion? That can be, you know, building a rapport, but also understanding where they come from to frame the conversation in a way that is conversation inclusive instead of divisive. Oh, I feel like I'm rambling at this point. Is this helpful? Thank you for coming to my TED Talk. But does that help, or do you want a little bit more? Do you want me to?
No, that helped. I was a lot about like meeting people where they're at, I think was something. And we had previously talked about creating a safe environment, which I think also is something that might really help, is if you like make the mindset and the environment match what like the growth that is expected.
Yeah. And also understanding, and this is kind of something that I have adopted in my profession as an advisor. I have tons of conversations with people. I have tons of conversations that have nothing to do with healthcare and academics with people, that have everything to do about life, love, and everything in between. And the person that you have this conversation with, you know, be it your patient, be it your friend, whatnot, you may never see them get there. You may absolutely never see the change. You know, if you are a provider that's having a conversation with your obese patient about, listen, my friend, like, we need to stop with the cheeseburgers, like you're going to have a problem. They may get huffy and leave, and you may never see them again. But you have no idea of knowing that maybe 6 months later, they're like, yeah, no, I need to do that. They enroll in some sort of Weight Watchers, they get the weight done, and they're living their best life. You know, you may never know that the conversation with the older gentleman you have about bias and about equality, he may leave in a huff, but he could leave with some nuggets of information and think on it, and later, you know, change his mind and change his worldview. You know, we never know where we meet people in the process of their life. And so the best thing that we can do is be as inclusive and understanding and open as possible, and welcome conversation and encourage thought and exploration, and hope that, you know, they take it with them and it leads to change.
I'll add to that, that never go into a conversation trying to make somebody change. You should never enter into a discussion trying to make somebody see your way, because that's the wrong, you're already messing it up, because you have to figure out where they're at, and it should just be a conversation. Even though you want to bring information to light, the process of the conversation is just that, a conversation, right? So trying to enter into a discussion on something for them to come your way, you're going to be bottling yourself.
That makes sense.
And there's that being aware of our own bias and embracing our own bias comes in. It's a good question for all aspects of life. Other questions or thoughts? No? Okay, well, we will cut short a little bit. I think this is a fantastic conversation. I definitely want to extend a hearty thanks to Shannon, to Jasmine, to Rosetta for coming and for talking and for sharing their expertise and their ideas and thoughts. Hopefully you guys take away some nuggets of information that you can think about diversity and inclusion in healthcare. And if you're planning on becoming a provider, you can carry this with you, and hopefully it makes you a better provider. And then of course, thank you to our guests, to our students for coming and asking questions and engaging. You guys have, you know, additional thoughts and questions that you think of after this is over, feel free to reach out to me. My information is on the pre-health advising website on UTC Pre-Health, and I can connect you with our speakers if you have additional questions for them. But stay safe, guys. Have a good evening, and don't lick doorknobs.
Bye.
Bye, everyone.